Chapter 18, Cardiac Emergencies. This chapter is probably one of my favorites. As a matter of fact, I would say it is my favorite. Everything we talk about through the entire semester revolves around the heart and the heart's ability to function appropriately. And at the end of the day, whenever we run into patients who are sick and we can't really define what's wrong with them or identify the underlying problem, we resort back to something called it's cardiac until proven otherwise. So understanding how the heart works, understanding what can go wrong with the heart, and most importantly, understanding what it is that we can do to fix it is really important. These are issues a lot of times that we can identify readily, easily, and things that we can fix relatively quickly. If you look at your protocols, especially the ALS components of them, there is quite a bit of work that can be done for the heart, from electroshock therapy all the way down to different medications and drugs that can be given. So as you progress up through the paramedic ranks, you'll begin to learn that there's really quite a bit we can do to try to help the heart out. So we'll begin by reviewing some of the basics, anatomy and physiology. These are all things that we have talked about extensively in the past, and especially understanding how the heart and its function relates back to the concept of perfusion or lack of perfusion in that case. So looking first and foremost at the anatomy of the heart, we remember that it's got four primary chambers: the right and left atria that sit up on top, and the right and left ventricles that sit on the bottom. So if you don't already, you need to understand the path of blood flow through the heart. So blood itself enters the heart, it returns back through the inferior or superior vena cavas, and it dumps here into the right atria. From there, the right atria contract, and it pushes it through this tricuspid valve, and the tricuspid valve opens up, allowing the blood into the right ventricle. During the next contraction, blood is then forced out through the pulmonary valve here, and it goes to each of the lungs, where it gets rid of its carbon dioxide and takes on oxygen. Once that occurs, blood returns back through the pulmonary veins and into the left atria. Now remember that the pulmonary artery and pulmonary vein are the only vessels in the body that are flip-flopped as far as oxygenation. So every single vein in the body carries deoxygenated blood except the pulmonary vein. And every single artery in the body carries oxygenated blood except the pulmonary artery. So those two are flip-flopped, okay? So anyways, the blood returns here into the left atria. Atria contract, pushing it through the mitral or bicuspid valve. You'll hear it referred to as either one. And there it enters into the left ventricle. Now notice the left ventricle here and how muscular it is, right? The muscle around the left ventricle is a lot thicker than it is anywhere else in the heart. And the reason being is this is where we need the greatest force of contraction. As this left ventricle contracts, it forcefully pushes blood up through the aortic valve, through the aortic arch here. These are your carotid arteries going up toward the head, and from there it perfuses the entire body. So this one left ventricle, this one chamber here, exerts enough pressure to force blood out all the way to the most distal parts of the body, all the way down to the tip of your toes. Okay, so as you can imagine, it is very muscular. We have a series of things that can occur that reduce blood flow, and we've talked about congestive heart failure in the past. We've talked about how that can relate to pulmonary edema and shortness of breath and everything else. Well, some of the things that can happen is we can have valve issues here. These valves are closed by default, and then they open up when blood is forced through. And as soon as that blood is forced through, the valve closes again. From time to time, those valves don't function appropriately, and they don't close all the way, or you could have what's called a leaky valve. And when that happens, it's possible for blood to be pushed back through. So think about when the right ventricle contracts. As long as the valve is closed 100%, then the blood is diverted out here through the pulmonary artery. But if we have a leaky valve here, it's possible that some blood could actually be pushed backward back into the right atria here. And when we have blood flow in the wrong direction, you can pretty much imagine how that affects our cardiac output, right? That means less blood in equals less blood out, and we're going to have a lot of issues as far as blood flow. We're going to have issues with circulation through the lungs. Pulmonary edema could begin to develop. We could also start to see things like pedal edema, sacral edema, and it could also build up a lot of fluid in the lungs. So those are some things that we could look at. From time to time, there may be areas of the heart that have been damaged in the past from maybe a heart attack. And let's just say that, as you can see, the vessels that come down here, right, on the side of the heart wall, Let's say that a clot got lodged right in this area here. And as a result, this area of tissue around the heart has now been permanently damaged. That could affect the right ventricle's ability to pump blood as effectively as it should. And as a result, we could have, again, an issue with circulation. And these are all different types of things that can ultimately lead to a diagnosis of congestive heart failure. From our perspective, we're never going to be able to diagnose these problems in the field, but if the patient has a previously diagnosed issue and they can provide that information to us, then we know that circulation could be an issue, blood pressure as far as cardiac output could be a problem, and we definitely have to watch for signs of pulmonary edema. Beyond that, know everything else in here. I gave you the basics here, but you guys really need to understand what all these things are. You need to be able to label these things, including the pericardium, the myocardium, the endocardium. Know all of those terms. All right. And this is just exactly what I talked about. It just has it numbered now as far as the direction that things travel throughout the body. Okay. So, you know what? Actually, let's go back for a quick second here because I do want to talk a little bit more about the electrical systems of the heart. So, the electrical systems of the heart are just as important as anything else that's labeled on here. If the heart isn't firing properly from an electrical standpoint, then we don't have the proper contraction. And as a matter of fact, I'm going to go ahead and pull up the slide that shows the electrical physiology of the heart here so we can discuss how that works and how that impacts things. Okay, here's the slide. This actually required us to jump back to chapter 6, but here's a slide that shows the cardiac conduction system. So if you look up here, we have the sinoatrial node, and a node is just a bundle of cells that are kind of grouped together. And collectively, this node is considered the pacemaker of the heart. It's located here in the right atrium. And as that node delivers its big bolt of electricity, it travels along what's called these internodal pathways, right? They're little streets or roads, if you will, that allow that electrical impulse to travel relatively unobstructed. But as it travels along these pathways here, it actually transmits itself into each of those cells. And the cells themselves, through the process of automaticity, have the ability to take in that energy and deliver that energy to the next neighboring cell. So that energy is quickly delivered throughout the atria. So when you listen to the heart, especially with the stethoscope, you hear boom, 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 boom. That first beat that you hear is actually the atria firing. And then after that, you hear the ventricles firing. So it goes to show how quickly that electrical impulse is transferred throughout the heart. It's just a split second. Once the energy is delivered throughout the atria, it recollects itself here into what's called the atrioventricular or AV node. And again, that node is a bundle of cells. It collects that energy, it holds that energy for just a split second, and then from there, it delivers it down through the what's called the bundle branches and eventually into the little Purkinje fibers, and it does the same thing. These are just little pathways that allow for that energy to be transmitted without very much resistance, and then it branches off into the myocardium itself, and it delivers that electrical impulse to the remaining parts of the muscle here. So there are lots of things that can happen here. We hear things called cardiac dysrhythmias all the time. We know that our AEDs use energy to shock ventricular fibrillation back into a perfusing rhythm, and these are all things that we should keep in mind. Now, understanding rhythm interpretation is outside of the scope of an EMT. However, it doesn't mean that you shouldn't at least be familiar with it. So let's take a quick look at how the cardiac conduction system relates itself to the monitor. When we're looking at the monitor, what is it that we're seeing? And let's see how it all begins to make sense. So here's a nice picture of a basic electrical complex that we would be looking at the heart. This is textbook, pretty much what we would expect to see. And what you have here is this P wave. This P wave actually represents when the atria contract. So when we see this first little bump in the complex here, that tells us that the atria are contracting themselves and that they're contracting together. Okay. And then here we have a small pause, if you will. This is the point where the AV node captures that electrical activity and holds on to it just for a split second. From there, then, it's released from the AV node, and it's delivered down through the Purkinje fibers, right? And as it delivers throughout the ventricles here, the ventricles contract. And that's a big, mighty contraction because, again, from the right ventricle, we want to be able to push it all the way out to the lungs and throughout the lungs. And from the left ventricle, we want to be able to push it all the way down to the toes, the most distal parts of the body. So now we have this large spike here. And this large spike, called the QRS complex, that is a representation of the ventricles contracting. And then from here, we again have a small pause, and then we have what's called the T wave. And the T wave is repolarization. So that's where everything resets itself. And getting into a little bit more in-depth pathophys, stuff that you'll cover more in paramedic, you have something called the sodium-potassium pump. And under normal circumstances, your blood is filled with the electrolyte sodium, and inside the cells, you have potassium. When we have depolarization of both the atria and the ventricles here, the potassium and sodium switch places. The potassium pushes itself out into the blood, and the sodium gets drawn into the cells. And that's what allows for that electrical depolarization. When we want to reset and get ready for the next heartbeat, it repolarizes itself, and the sodium goes back into the blood and the potassium back into the cells. And that's just a very basic rudimentary explanation of how it works. But that's essentially what we're looking at. So this P wave, or the first little bump, this is the atria contracting. This big spiky QRS complex, this is the ventricle contracting. And then that bump that comes afterward, the T wave, this is everything beginning to reset itself. Now you will spend an entire month just talking about different electrical complexes, different rhythms and stuff like that. So this is literally just the most basic introduction you can ever imagine. But some things that you'll begin to hear in classes, we'll start talking about things like a STEMI, right? An ST elevated myocardial infarction. And those are typically indicative of a heart attack. And what we're looking for there is essentially the ST segment. So here's your S wave, here's your T wave, right? The segment that goes between it, if it is elevated above baseline. So if I were to draw a straight line all the way across here, this is my baseline. If this line here was actually elevated, right, it comes up, comes down, and then it branches off up here, and then my T wave starts. That elevation is a sign that there's some type of issue going on with the heart muscle, and we could diagnose that as a potential heart attack. So again, don't go diagnosing things. Don't spend any time trying to interpret rhythms. I gave you just enough to be dangerous at this point, certainly not enough to actually understand what's going on or how to interpret things. Okay, if you really want to know more, we can talk about that after class someday. Okay, so let's start talking about acute coronary syndrome, or ACS. Now, this is actually a specific protocol in your protocol book. The acute coronary syndrome is just simply anything having to do with the heart that seems to be irregular. It could be something as simple as chest pain, or it can include reduced cardiac output, and stuff like that. So, sometimes called cardiac compromise, the acute coronary syndrome is something that we'll refer back to anytime we believe that the heart is being compromised in any way to the point that it's not receiving the appropriate amount of oxygen. Whenever that happens, whenever the heart stops getting the oxygen it needs, it gets very irritated. And the patient's going to know that it's irritated either through the form of chest pain, or they could start to feel a fluttering in their chest. They could just generally feel very weak and ill, signifying that their blood pressure is dropping and they're not perfusing very well. If the cardiac output is compromised and they're not perfusing the brain, we could start to see things like altered mental status, or even shortness of breath if we're not circulating appropriate volumes to the lungs, or worse yet, if we're sending too much to the lungs, but we're not able to get the fluid out of the lungs, then that pulmonary edema and the ensuing shortness of breath, those are all indications that we could have some type of cardiac compromise. So essentially what I just said is that if the patient is confused, it could be cardiac in nature. If it's short of breath, it could be cardiac in nature. If they have chest pain, it could be cardiac in nature. If they have numbness or tingling in the extremities, that could be cardiac in nature. So at the end of the day, everything could potentially be cardiac in nature. And that makes it tough. We need to get really good at evaluating our patients and being able to differentiate between a possible cardiac issue as compared to maybe a an issue with kidney stones. Maybe it's just a respiratory issue like asthma. Patients who have asthma, they may complain that they have a tightness in their chest because, in fact, their bronchioles are all constricted. Now, that tightness in the chest could also be used to describe, chest pain from a potential heart attack. Our treatment, though, of a heart attack compared to the treatment of asthma are very different. So that's where we need to really understand the differences in the presentations there, be able to kind of rule out some things, confirm others, and come up with an appropriate treatment plan. So here again, it says symptoms often mimic non-cardiac conditions, just reinforces what I just said there. We need to treat all patients that have chest pain or ACS-like symptoms as if they are in fact having a heart issue. Okay, not necessarily a heart attack, but at least a heart issue. And for EMTs in the field, it becomes more difficult to diagnose. There are possibilities now, and it's within your scope to acquire an EKG and to wirelessly transmit it to the hospital for interpretation. So as an EMT, you will be expected to know how to use the EKG, how to properly place the electrodes, how to acquire the actual diagnostic test itself, but you won't know how to interpret it. Okay, that's something that the doctor will do. And because of technology that we have through Bluetooth and Wi-Fi on our ambulances, we're able to actually send that wirelessly to the hospital, and the doctor can look at it on a computer screen while you're still sitting in the patient's living room. Okay, really neat technology. But in regards to that stuff, even if we can't diagnose it in the field, we still have to make some assumptions from time to time, and we may have to base that strictly on signs and symptoms and an OPQRST assessment. Even for me as a paramedic, I may do an EKG and interpret it and say, okay, no, I don't see any signs of an ST elevated MI. I don't see any ST segment elevation there. But that doesn't mean that the patient's not having a heart attack. I can also have something called a non-STEMI, right? And that means that I have to be able to look at the signs and symptoms, evaluate my patient's condition, weigh that up against their vital signs and other presentations, and determine, okay, no, they're not having any signs on the EKG of a heart attack, but they may still be having a heart attack. And ultimately, the most definitive way of determining if somebody's having some issue going on with their heart is through blood work that can be drawn. Okay, they can do much more advanced imaging at the hospital. They can draw that blood work. They can test for certain cardiac markers that suggest that the heart is upset. At the end of the day, the hospital is the place they need to be. So even in the back of an ALS ambulance, that's only going to do a little bit, but we cannot make any final decisions or diagnosis in the back of that ambulance. So whenever we think of heart attack, we associate that with chest pain. And that's certainly going to be a big indicator. When somebody has chest pain, we should immediately start thinking about heart attack. However, I can't count the number of times that I've had a patient having a heart attack that didn't have any chest pain at all. As a matter of fact, it is a number so large that I bet it would be somewhere in the hundreds, right? I've seen thousands of patients in my career, and I bet hundreds of them have presented with an MI that have not had any heart or any chest pain. And there's certain demographics that will present without chest pain more often than others. In general, we look at the elderly as potentially not having chest pain or not experiencing it the way we would typically imagine. Diabetics are the same. And in general, women can present differently, but especially women that are beyond the point of menopause, right? We have changes in the hormonal structures of the body there. There's changes in the way the pain is interpreted, especially with our elderly and diabetic populations. And as a result, they just may not feel that pain like we would expect them to. In addition to that, sometimes people may have pain, but they're having such a problem breathing that they're distracted from the pain. Their focus is on the fact that they can't breathe right now. And as a result, the pain, although it's there, is not really, it's ignored for all practical purposes. And they fail to let us know that they're experiencing pain. So that's why it's important that we begin to ask appropriate questions. We should begin with open-ended questions when we're interviewing our patient, allowing them to describe in their own words what they're feeling and generally what they think is going on. From there, once we've given them the opportunity to do that, we can begin to ask more targeted questions that allow us to kind of confirm or deny things. So I could, if the patient says, yeah, I woke up in bed and I was sweating real bad and I can't breathe. Okay, there's our chief complaint. They said it in their own words. Now I could go back through and say, okay, do you feel nauseous or do you feel like you need to vomit? Are you experiencing any numbness or tingling? Do you feel weak or dizzy? Uh, are you experiencing any chest pain? And if they say yes, they are experiencing chest pain, I could say, okay, do you feel that pain anywhere else in your body? And I want to make sure that I try to leave it as open-ended as possible to allow them to describe it before I go into leading questions. If they say, yeah, I feel the pain, it's in my back, or I feel it in my abdomen, or I feel it in my left arm, or neck or jaw, those are all suggestions that it could be cardiac in nature. And before I come out and give them all those options, I'd rather that it be a short answer type question rather than a multiple choice, right? Give them the opportunity to describe their signs and symptoms in person in their own words, and then from there, if we're not getting the information that we need, we can go in and begin to ask some more leading questions. Okay. Shortness of breath corresponds along with it without a doubt. A lot of times, if the heart's irritated, uh, not only will we actually be short of breath, but that sensation may be there just simply because of the chest pain. But if the heart is having an issue, if we are having a heart attack and cardiac output is compromised for whatever reason, then that's going to affect the ability to, pump blood through the lungs like we need to exchange those gases, and therefore we'll have that shortness of breath. Also, going back to the chest pain, it's really important to understand the different presentations. If somebody says that they have a real sharp pain in their chest, I don't typically associate that with cardiac. I think that maybe they have a spontaneous pneumothorax. I think that maybe they could have a pneumonia. I think maybe they pulled a muscle from a cough. There's lots of things that could be going on that would cause those sharp pains. But when they describe it as a pressure or a dull pain or squeezing, I had a patient the other day say it felt like somebody was just giving him a big bear hug around his chest. Those are the types of things that would push me more in the direction of something being cardiac in nature. You've got a handful of other symptoms here that are listed. Note at the bottom the abnormal pulse or abnormal blood pressure. It could be fast, slow, high, or low. And that's why they just simply left it vague there. It depends on the area of the heart that's being affected. And you need to know that when we're having a heart attack, it's not necessarily the entire heart that's affected. More times than not, it's a single blood vessel that perfuses a single area of the heart, and that's where the issue exists. Only rarely is there an issue that affects the entire heart at one time. And that's actually something that we refer to as a widowmaker. And usually when we're watching TV or watching the movies, somebody's walking along having a great time, all of a sudden they clench their chest, they fall over dead, right? That would actually be an indication of a widowmaker. Those are not very common whatsoever. And when we do get to patients that have the widowmaker, more often than not, they're going to be in cardiac arrest, not awake and talking to us. But the vast majority of our heart attacks affect single blood vessels lower down in the heart that still allow the patient to function and remain alive, especially long enough to get onto the cath table at the hospital and try to restore that blood flow. So when a patient is complaining of any of those things, nausea, vomiting, shortness of breath, weakness, dizziness, chest pain, anything else, we have to first and foremost rule out the possibility of it being cardiac in nature. And we're going to do that through a good comprehensive assessment that includes a detailed sample and OPQRST interview. We're going to look at vital signs to see if, is their heart regular or irregular? Is their blood pressure low, indicating reduced cardiac output? And we're going to go through the steps there. Okay. If we can rule out cardiac, then we should start going down the road of other things and asking questions that would help us to confirm the presence of maybe some other underlying illness and allowing us to come up with an appropriate treatment plan. We can look at the patient's overall positioning. We can look at something called Levine's sign. That's where they're actually clenching their chest. And that is a basic response. It's a natural response that the body has. Whenever we experience pain or discomfort, we typically do something called guard the area. And think about that. If I were to walk up to somebody right now and punch them in the gut, what do? They keel over automatically. They bring their arms up and they wrap them around their stomach and they guard that area. That's a natural response. And the same thing happens if the pain is felt in the heart. Naturally our hand goes up to our chest and we're trying to block that area. It's the body's way of trying to prevent any external influence from inflicting any additional pain, because the body doesn't necessarily know where the pain itself is coming from. So just keep that in mind. Whenever somebody is guarding a certain area of their body, that could typically indicate where they're feeling the pain or discomfort, and maybe give us a clue as to what could be going on. So this patient here, the care provider has started doing some vitals. They've got the patient on oxygen, and oxygen is something we got to talk about entirely. And then at the same time, she's asking some questions to the patient's wife. Now, keep in mind, our patient here is the best historian. We want to ask our patient the questions first and foremost. If the patient is altered, maybe the patient has dementia, or for whatever reason we're unable to get good information from our patient, that's when we can resort to bystanders. Now, that being said, we also want to consider, okay, if our patient is a 15-year-old boy, I can promise you that at the age of 15, I knew very little about my medical history, but my mom could have told you every single thing, probably down to the date that it occurred, okay? So we want to make sure we're getting the good information. Start with your patient. If you're not getting what you need, you can move on to family, bystanders, or anybody else that may be able to help out. So when a patient is experiencing what we believe to be an acute coronary syndrome, it may be appropriate to administer things like nitroglycerin. Okay, nitroglycerin is administered for chest pain. Period. There's no other indication for you as a BLS provider at this point to give nitro other than the presence of chest pain. So if the patient says, "Yeah, I have chest pain," and you believe that chest pain to be cardiac in nature, give the nitro. Now, here's the caveat, right? I said if they have chest pain and you believe it to be cardiac in nature. If I were to walk up to somebody and hit them in the chest with a baseball bat, would they have chest pain? Of course they would. Would that chest pain possibly be indicative of some type of internal bleeding from that blunt force trauma? Yeah, there's a good chance of it. If I give nitroglycerin to the patient, is it going to make that bleeding a lot worse and drop their blood pressure a lot lower? Absolutely. So obviously, chest pain from trauma would not be appropriate to give nitro. As a matter of fact, that would be a contraindication to give that nitro. Chest pain from a pneumonia or a bronchitis or a spontaneous pneumothorax. These are all chest issues that happen in the thorax that cause pain, but would not be appropriate to give nitro. So it needs to be chest pain, and there needs to be a reasonable belief that it's cardiac in nature. So the pain is described as squeezing or a pressure. It's substernal, meaning that it's originating beneath the sternum. The pain radiates off to the left arm, or either arm really, but especially the left arm, the left jaw, or the neck. These are all things that confirm that it's likely cardiac in nature, and those types of presentations would be inconsistent with a pneumonia, a bronchitis, a spontaneous pneumo, a pulled muscle, right? Those things would all be presenting differently with pain than the heart attack would. So if I believe it to be cardiac in nature, nitroglycerin would be appropriate, okay? A lot of times patients are prescribed nitro, and these are patients that have gone to the doctor in the past and say, "Doc, I get winded, I'm out of breath every time I climb the stairs. I go to play with my grandkids and I'm exhausted." Those types of things. And the doctor orders some tests, they do some imaging, and the doctor says, "Well, Scott, you're 40% blocked in your, you know, such and such artery, and we're going to schedule you for a surgery, but in the meantime, here's some nitroglycerin." Okay? And that prescription goes home with the patient, and the patient's instructed if they start to develop chest pain to take that nitro right away. In addition to that, if the patient is prescribed nitroglycerin, the dispatcher may instruct them to take the nitro. The dispatcher will also instruct them to take aspirin if appropriate. Okay, so these are all things that can be done to try to address the potential for a clot inside the lungs or inside the heart there. Okay, that nitroglycerin, though, if the patient is not prescribed it, is carried on BLS ambulances in the state of Illinois. So you can actually get your nitroglycerin out and you can administer it yourself. Keep in mind that in some areas you may have these nitroglycerin tablets which go underneath the tongue. They're dissolved sublingually, but there are other places that actually carry sublingual sprays. So it's a nitroglycerin spray where you just tell them to lift their tongue, you give it a quick spritz underneath the tongue there, and it does the same thing. Moreover, we need to watch out for patients, especially in nursing homes, that have nitro patches. So patients who have chronic cardiac issues and need that routine release of nitroglycerin to keep the blood vessels dilated, they may actually have a patch on. So we need to get a good medical history from these patients. If the patient does have a nitro patch, we want to potentially remove that before we would administer supplemental or a supplemental nitro. And the reason being, if we're doubling up those nitro dosages, we can start to see some pretty significant drops in blood pressure. And the other reason is if the patient's still having chest pain, despite the fact that they have a nitro patch, maybe that nitro patch isn't working. Maybe it hasn't been changed recently like it's supposed to. So if we're going to give the nitroglycerin, we need to make sure that there aren't any contraindications, right? The purpose or the intended action for nitro is to dilate the blood vessels, allowing blood flow beyond the point of the clot or the obstruction. That's it. That's why we're trying to give it. Now, there are side effects that come along with that. And the dilation of the blood vessels will cause a drop in blood pressure. That's one side effect. It may cause dilation of the blood vessels in the brain, allowing additional blood flow up there, and it causes a headache. There's another side effect. Even though those side effects may or likely will occur, the benefit of that vasodilation and allowing blood flow beyond the point of the clot outweighs those potential side effects. But there are times where the side effects may outweigh the benefit. Case in point, we have a requirement here that the systolic blood pressure meets protocol criteria. So if in your protocols, and generally speaking for the exams in class, we want that systolic pressure to be above 100. We anticipate that there's at least going to be a 10-point drop in the systolic pressure after you give that nitro. So we want the systolic pressure to be above 100 before we give the nitro in the first place. And as we give that nitro and the pressure drops, we don't ever want to see the systolic pressure drop below 90 if we can avoid it. And having a systolic pressure of 90, although that's low, still allows for appropriate perfusion of all the vital organs. If the blood pressure initially was 86 over 50, and then we give them a nitro, and it drops their blood pressure now to 70 over 40, that is insufficient. Now we are not adequately perfusing all the vital organs. So we need to make sure that their blood pressure is high enough in the first place to give the nitro. So again, we're looking for that systolic pressure above 100. But now again, looking even beyond that simple concept. Let's say that the blood pressure initially is 140 over 90. That's perfect, not a problem. We can give the nitro, no risk, right? Well, with minimal risk. So I give a nitro with a blood pressure of 140 over 90. I reassess because I have to reassess after I administer any medication. And now the blood pressure is 118 over 78. Hey, that's still a good blood pressure. That's still above 100, right? But let's look at the change. So the initial blood pressure was 140 systolic, and now the blood pressure is 118 systolic. So I saw a 22-point drop from that one nitroglycerin. If I give another nitro, I would expect to see another 22-point drop at least. Realistically, it's probably going to be more than a 22-point drop. So if I'm at 118 now, technically I meet my protocol requirements. But if I am expecting a 22-point drop or greater, 118 minus 22 takes us down to, what does that put us at? 96, right? So now the blood pressure is theoretically going to drop down to 96 or lower. Now that's still a perfusing pressure, right? We're still getting blood to the vital organs, but I'll tell you what, I'm nervous at that point. I don't like it when my patient's pressure gets down in the 90s there. I start to get a little nervous. So I need to decide, is it appropriate or not to give this next nitroglycerin? And if I'm uncertain of it, I can always call the hospital, call medical control and say, hey, I had a 22-point drop on the first nitro. I'm anticipating it's going to drop again. How do you guys feel about this? And get a little bit of feedback. You should never hesitate to call medical control and bounce your ideas or concerns off of them. We all work together as a team. Beyond the blood pressure requirements, we also have to look at, have they taken any type of erectile dysfunction medications? Viagra, Levitra, Cialis, there's a whole bunch of medications that are out there these days. And the way that those work is they actually cause Vasodilation, no different than the nitroglycerin, right? The function of these erectile medications is to cause that vasodilation in the penis, allowing the patient to actually get an erection. The issue here is that if they've taken these medications within the last, and you have to look at the different meds, Viagra, Levitra, Cialis, they all have different criteria, but within the last 24 to 72 hours, and now we give nitro on top of that, it can cause a very dangerous drop in blood pressure. So we have to really be careful. Now, what we're going to run into here is, you've got this 48-year-old male patient who, he's not old, but he's not young, and he's secretly taking Viagra because he's trying to improve, extracurricular activities in the bedroom. If we just simply come out and say, hey, by the way, are you taking any Viagra or anything else? They may be embarrassed to actually answer you honestly. So when we're asking this question, we want to be very direct. Sir, just so you know, we're going to give you a medication that causes your blood vessels to dilate, and it's meant to treat this chest pain. However, if we give it in conjunction with any erectile dysfunction medications, such as Viagra, Levitra, Cialis, or anything else, it can actually cause a very dangerous response. Are you taking any of those medications at this time? And just simply ask them that and allow for that yes or no. And then if they say yes, say, okay, can you tell me when was the last time that you took one? And if they tell you that it was, 6 days ago, that's not a big deal. We should still be able to give the nitro. But if it's within that 24 to 72 hour period or less, obviously that's something that we would probably want to withhold it. Okay. So just again, some things to consider. In addition to that, this is a medication. Make sure that you're asking your 5 rights: right patient, right dose, right medication, right route. And what am I forgetting here? And right date. Okay, make sure it's not expired. So after giving 1 dose of nitroglycerin, you can repeat that in 5 minutes if everything still remains above where you need it to be. Okay, we're really watching the blood pressure at that point. And warn the patient that they are probably going to get a headache from this. Okay, that's very common for them to get a headache after the nitro is administered. So here it says patient not allergic to aspirin. We're talking about the administration of aspirin or ASA. Let's first talk about the indications for it. If they're having chest pain, and again, you believe it to be cardiac in nature, you can administer it for the chest pain. Now, what we're doing here is the aspirin actually makes the platelets somewhat slippery. The aspirin prevents the platelets from sticking to each other, and it slows the growth rate of the clot. So in that circumstance, that's what we're doing. This is not administered for pain whatsoever. Again, I'm going to say that one more time. We are not giving aspirin to treat the chest pain. It has nothing to do with it. It will not address chest pain at all. Okay? Now it says here, patient not allergic to aspirin. Of course, if somebody's allergic to aspirin or any other medication, we wouldn't give it. That would be a contraindication. Now, I don't like the next bullet point, though. It says no history of asthma. That's not true. What is true is that for some asthma patients, aspirin can exacerbate a reaction. It can actually cause an asthmatic reaction to occur. Ask the patient, do you have asthma? If they say yes, say, can you take aspirin? And if they say, yeah, I take aspirin all the time, it's no big deal. Perfect. You can give them aspirin. If they say, oh no, last time I took aspirin, it gave me a terrible reaction, then we don't give it. Okay. Simply having a history of asthma is not a contraindication to asthma, or is not a contraindication to aspirin. Okay. So we need to get a little bit more in depth with that line of questioning. And then if they are taking any other medications to prevent clotting, we need to keep that in mind. So if they're taking some type of blood thinner or something else, it may not be appropriate to give the aspirin. Refer back to your protocols and contact medical control in those circumstances to get a more definitive response on whether or not you should give it. The other thing we have to ask, though, is whether or not they recently took the aspirin. It is very common for the emergency medical dispatchers, while taking a 911 call for chest pain, to instruct the patient to take the aspirin. So if they say, yeah, the dispatcher told me to take aspirin and I already took 324 milligrams, perfect. Now you don't need to give it again. Okay? So as long as there's nothing else, no other contraindications, they're awake, they're conscious, they can swallow without risk of choking or aspiration, go ahead and administer it. But of course, remember that all medications at the BLS level, with the exception of oxygen, require you to obtain medical control authorization prior to actually giving it. The aspirin itself is administered in 4 separate tablets. Each tablet here is 81 milligrams, and we give them a total of 4 tablets, reaching 324 milligrams as our total dosing. Okay. So from here, we'll move into causes of cardiac conditions. And ultimately, there's countless numbers of different conditions, diseases, illnesses that can impact the overall function of the heart. But we'll talk about some of the more common ones and ones that will help give us an idea of what we may be dealing with depending on our patient's presentation. So looking at coronary artery disease, you'll see that abbreviated as CAD. Essentially what ends up happening is you get fatty deposits that build up within the arteries themselves, and those fatty deposits end up constricting things down, and it reduces blood flow through those vessels. With these patients, these are the ones that are typically prescribed nitroglycerin in advance. These are the patients that I talked about just a few minutes ago where they get really tired or winded walking up a short flight of stairs, or any type of general activity fatigues them. They typically go to the doctor, and this is what they are diagnosed with. This is also the byproduct of poor eating. So when we look at patients who have a relatively sedentary lifestyle, maybe they are grossly overweight or obese, these are all indicators that even if not diagnosed with coronary artery disease, there's still a pretty high likelihood that that could be present. So with coronary artery disease, we have 2 potential risks, one of which is going to be a thrombus. And that thrombus, essentially, as the fat builds up within the layers of the arteries themselves, it's actually within the lining of the artery. That artery lining will continue to stretch as that clot, or as that fatty buildup continues to grow. Eventually, the inner lining of the artery wall will rupture, exposing that fatty buildup to the blood supply. And as the blood supply becomes exposed to that, the platelets will begin to bind to it, and it begins to form a clot. And that clot is then what we would refer to as a thrombus. Okay, that thrombus will continue to build. The reason we give aspirin now is for this very purpose. As that clot continues to build with every platelet that passes by it, if we can get the aspirin on board right away, then it will prevent those platelets from sticking, and it'll slow the growth rate of that clot. In addition to that, we give the nitroglycerin to further dilate the blood vessel, and we should be able to navigate a sufficient supply of blood around the site of this thrombus then. From time to time, the thrombus can break loose, and if that breaks loose, if it becomes a free-floating clot, we then refer to that as an embolus or an emboli. Not only can a thrombus break loose causing that, but the other problem is that from time to time, people, especially people with a history of atrial fibrillation, clots can begin to form just because the blood is kind of pooling within the atria. So with atrial fibrillation, the atria are quivering instead of contracting like they're supposed to. Blood supply or blood flow through the atria is inhibited, and as a result, you get some stale or stagnant blood that builds up in there, and we have a potential for clots to build. This can also happen post-surgery. If somebody has recent history of a surgical intervention and they're in the healing process, as the blood vessels that were impaired by the surgery begin to heal, it is potential for a clot to break loose and become free-floating. So anytime we have a free-floating clot for any one of those reasons, we would refer to that as an embolus. And what happens is that will continue to flow through the arteries, and it'll go through smaller arteries into arterioles, and eventually, once the same diameter of that clot meets the diameter of the artery, it gets lodged there and it blocks off. Now, with this patient, this is where we can start to see that widowmaker that I mentioned. If it is a very, very large clot, and that large clot gets out into the coronary arteries, and it gets lodged at the very, very top of the heart, right where the coronary arteries begin to branch off from each other. If it gets lodged into one of the major blood vessels there, then it will occlude all of the blood flow beyond the point of that vessel, and that can cause the patient to go down immediately. That would immediately stop all supply to the heart and the heart would go into heart failure and ultimately into a VFib and cardiac arrest, probably within about a minute or so. So coronary artery disease, big thing is it reduces the ultimate blood flow to the heart. Now, beyond the point of having a heart attack, I mentioned that these patients are the ones that will have nitroglycerin prescribed to them. The difference between angina now and an actual heart attack or an MI is going to be whether or not that pain subsides. So a patient who has coronary artery disease has a prescription for nitroglycerin. They start to develop pain because they've increased their oxygen demand. So let's say that this patient with the CAD diagnosis, they decide to go to the mall and walk around. After a period of walking around, the amount of oxygen being consumed by the body to meet the needs of that additional activity, the amount of oxygen that is required is now in excess of what is able to be delivered because of the reduction in that artery, right? With the coronary artery disease, the diameter of the artery is reduced, and therefore the blood supply is no longer sufficient to meet the increased oxygen demands from that additional physical activity. So the patient stops, they rest, and if that pain goes away within the next 15 minutes, then that is typically as a result of the oxygen demand going back down to the point that the blood supply is sufficient. So that would be an example of your angina. They're still at risk for a heart attack, right? That could still be the underlying cause, but with rest and a reduction in the oxygen demand, we're able to subside the pain. So with those patients, it doesn't mean anything, doesn't change anything. An angina patient versus an MI, we should still treat them the same. We should still transport them to the hospital. If the pain persists, we can go ahead and administer the nitroglycerin to them. No matter what, we treat these patients the same. It's just one way that we can evaluate whether or not this is a patient that likely needs to be treated or transported to the nearest cath lab, or if maybe they could go to a different hospital, depending on your resources and protocols. An aneurysm is the other option now for for a heart attack. In this case, the walls of the arteries within the heart are weakened. And that's typically a result of either disease or chronic untreated hypertension, right? So as the outside walls of these arteries are continuously stretched and stressed out, eventually they will rupture. And when that happens, then it allows blood to exit the coronary artery and bleed out into the pericardial sac that surrounds the heart. In this situation here, not only do we have a lack of blood flow beyond the point of the aneurysm, so all of the tissue beyond the aneurysm is going to become ischemic, but also now we have bleeding outside the heart. And as the blood continues to fill that pericardial sac, we're at risk for things like a pericardial tamponade, which is something that we'll talk about more once we get to trauma. And there's an illustration there of what it could potentially look like. We have the electrical malfunctions that could exist, and that's typically from some type of disruption to the electrical system of the heart. It could be either an issue with the heart itself, or it could be something as simple as electrolyte imbalances. Patients who are grossly dehydrated, patients who are suffering from something like heat stroke, where they're really dehydrated, or patients who are just simply sick or septic. Any of those things where the electrolytes in the body, where those levels are kind of thrown off, all of those things could result in electrical malfunctions. So that means that this isn't just people that are elderly, people who have weakened hearts. This could be a perfectly healthy 22-year-old marathon runner who is not, isn't well hydrated, runs, in weather that's warmer than normal, something like that. And any of those circumstances combined could potentially lead to electrical malfunctions, which is why hydration is so important. We also have the potential for mechanical malfunctions then. So mechanical malfunctions being the angina that I just mentioned, obviously the presence of an acute MI or myocardial infarction, and then also the potential for congestive heart failure, secondary to maybe an old MI or the valve issues that we talked about earlier, those types of things. So here's just another review of the angina. I'm not going to go back through this since I just explained it, but essentially, again, what happens is we increase the demand of oxygen that we need. The restricted blood vessel does not meet the demands of the oxygen, so it develops pain. Once we settle down, we reduce our activity level. The demand of oxygen also goes back down, and then the blood supply through that restricted artery now becomes sufficient. Talking about NMI, so there are essentially 3 different levels of damage that can be done to the heart. The first stage is ischemia, and what that means is that the heart tissue, and this applies really to any tissue in the entire body, not just the heart, but the tissue becomes deprived of oxygen. It's no longer receiving the complete oxygen supply that it demands, and as a result, it becomes irritated, and that is what we would call ischemia. If that goes a while without being treated, right, without restoring that oxygen supply, then we can see injury to the heart. And injury means that it may start, functioning or malfunctioning rather. We could start to see things like cardiac dysrhythmias. We can really begin to see a lot of chest pain. Maybe reduced cardiac output. There's damage to the tissues itself that cause it or impair its normal function. And then the third step then is what's called infarction. Infarction is true tissue death. And there is no coming back from infarction. Once an area of the heart has reached the point of infarction, that tissue is now dead in perpetuity. It will never come back. And again, that's why we could start to see, issues with congestive heart failure following a heart attack, where we're able to restore oxygen supply to the rest of the heart, but that area of the heart that the tissue died off, will forever be an issue. And it's also a possibility that depending on the extent of the damage, the location of the damage and stuff like that, the heart itself may never function sufficiently to maintain or resume a normal lifestyle. And those are patients that may have significant changes in their lifestyle. They may be bedridden. They could be put on a heart transplant list. A lot of different reasons that they may need to deal with there. So you'll see here, when the heart itself loses perfusion, right, then the extent of damage could radiate through the tissue all the way to the other side. What's important to understand is that even though if we're looking at a cross section here of the chambers of the heart, blood typically sits inside these chambers, but the blood does not perfuse the tissue. There are no capillaries inside these chambers to allow for the exchange of gases. So therefore, again, no perfusion occurs. The only way that this heart muscle is perfused is through these blood vessels that sit along the outside of the heart. Congestive heart failure, then, we've talked quite a bit about that in the respiratory chapter. We've also talked about that now today. So any number of things that can cause that congestive heart failure, but something has resulted in the heart not functioning as it should or sufficiently. Signs and symptoms of CHF, there's any number of things. So even looking at these things here, these are just very general signs and symptoms. Think about what CHF is, and it's the heart not working appropriately. So what are things that we could expect to see from that? Obviously, the heart could be too fast or too slow. It could be irregular, or it could be regular or irregular. Blood pressure could go up or down. Patient would have signs of general poor perfusion. They could be pale. They could be cyanotic. They could experience respiratory distress, especially if we start to get fluid back up in the lungs. So there's just so many different possibilities of how a patient may present with CHF that we can't simply look at them and say, oh, this is probably a CHF patient. We need to get a good sample history, a good overall assessment, identify the presence of maybe pedal edema or sacral edema. We could also listen to lung sounds, listen for rales or crackles to suggest that the fluid is in the lungs. These are all different things that we can use to try to narrow down that CHF may be the issue. And if you remember, if a patient is suffering from CHF, the most likely appropriate treatment would be the CPAP in that case. Anxiety. So CHF itself doesn't cause anxiety, but the hypoxia, the lack of oxygen throughout the bloodstream, that is what would cause anxiety. So in any circumstance, whether it's cardiac or not, in any illness, ailment, or injury where we're not delivering a sufficient quantity of oxygen, we could expect anxiety to set in. Okay. All right, cardiac arrest. So these are probably going to be one of the higher stress calls, as you can imagine. But as time goes on in your career, you're going to find that these are the easiest calls to run. It's very procedural. It's very simple. Cardiac arrest should not be an intimidating function or call to go on. We show up, we go through the procedures, we do some basic evaluations, and we do our best to bring them back. It's not rocket science, believe it or not. So reviewing the chain of survival, and everything we're going to talk about from here on out was covered through the American Heart Association in your CPR class. So there's going to be a few things that I skipped through here because you should have it or know it already, but I just want to talk about some of the more, some of the broader concepts that we need to keep in mind. So 5 elements of the chain of survival: immediate recognition and activation of the 911 system. Now for you as a BLS provider, immediately recognizing and requesting ALS would be along the same lines. Okay, early CPR. As soon as we recognize the presence of cardiac arrest, we want to be able to start those chest compressions. And the sooner we start the chest compressions, the sooner we can begin to reperfuse the cardiac cells with whatever oxygen is residual in the blood system. From there, then we want to immediately defibrillate. We want to defibrillate as quickly as possible. Every minute that goes by, we lose oxygen supply that's residual in the blood. The cardiac cells lose the oxygen that is perfusing them, and therefore we reduce the chances of successful defibrillation. The only way that defibrillation will work is if the cardiac cells are currently perfused with oxygen at that time. So if we don't get good compressions going, if we're not ventilating, if we're not delivering oxygen, if we're not perfusing those cardiac cells, the chances of defibrillation being successful are significantly reduced. From an advanced life support perspective, the sooner ALS gets there, we can get IV access. We can begin to dump fluids into the patient to try to restore perfusing pressure. We can also administer drugs that are called pressors, and those will help to constrict the blood vessels, further increasing the chances of perfusion. And then the most important thing, believe it or not, is number 5, that integrated post-cardiac arrest care. So if we can restore perfusion, if we get what's called ROSC, or return of spontaneous circulation, the sooner we can get the patient to the hospital and try to maintain not only the cardiac function, but maintain the patient's neurologic function, the greater the chances that they will have some type of positive quality of life following the arrest. In most cases, when we do restore a pulse, rarely does the patient wake up and say, "Oh, hey, I feel a lot better, thanks a lot." A lot of times they've still been hypoxic for such a period of time that the brain becomes ischemic, and they may have either temporary or permanent brain damage from that prolonged oxygen deprivation. So when we do get that immediate neurologic return where they can wake up and talk to us, those are few and far between, but boy, probably one of the most rewarding days of your life, I promise you. So we talked about rapid intervention, rapid recognition. Those are good. Early CPR. When we're doing CPR, there are multiple things that we have to keep in mind. And fortunately, with a lot of the newer monitors today, we have what's called feedback devices. And it will tell us if our compressions are the appropriate depth, if we're allowing for complete chest recoil, if we are doing it at the right rate, those types of things. So we need to make sure that they're good, high quality compressions. And we also need to make sure that we have enough people to effectively mitigate the arrest. A single person doing compressions, they're going to be exhausted in no time. So if you are a 2-person BLS ambulance and you're the first on scene and the remainder of your resources are 5 to 7 minutes out, don't be afraid to grab a trained layperson and ask them to assist you with doing compressions, right? There's absolutely nothing wrong with that whatsoever. Don't think that just because you get there that all of a sudden you have to tell everybody else to back up and let you work. Enlist the resources of bystanders who are willing to help, so long as they will in fact be a help and not a hindrance. So the most important thing to that high performance or high quality CPR is not only the depth and the rate and allowing the chest recoil, but also ensuring that we are minimizing or eliminating hands-off time to the extent possible. Over the course of the first 30 compressions that you do, assuming that we're doing 30 compressions to 2 ventilations, you are working to increase what's called the coronary perfusion pressure. So every compression you do, you're further increasing the pressure within the coronary arteries. And as that pressure continues to increase, eventually you'll get to a point where there's enough pressure inside the coronary arteries to perfuse the oxygen out into the cells. But that takes a period of time. It takes, out of 30 compressions, and depending on the quality of the compression, it could easily take 15 to 20 compressions before you get up into the appropriate perfusion pressure range. And once that happens, right, we go to 30 and then we stop. we deliver 2 ventilations. And those 2 ventilations aren't supposed to take more than 10 seconds. But I'll tell you what, over the course of the 10 seconds, you entirely drop down to 0 again with that coronary perfusion pressure. And now you're going to spend another 15 to 20 compressions getting back up there. So when we're doing 30 compressions to 2 ventilations, we spend very little time within the actual therapeutic range that allows us to perfuse the oxygen that we're pumping into their blood, that allows us to perfuse that into the cells. So what do we need to do? We need to make sure that we are minimizing interruptions to the extent possible. If you can, and remember that king tubes and i-gels are going to be included within your BLS scope, you can drop a king tube or i-gel into this patient right away. Even while your partner is compressing, you can insert one of those 2 airway devices. Once those are in place, you no longer have to do 30 and 2. Now it's continuous compressions without pause, without stop, and all you have to do is bag that patient every 5 to 6 seconds. In that circumstance, then, the only time we will stop would be every 2 minutes when the AED tells us to, so that the AED can analyze the rhythm and determine if a shock is appropriate. Remember that our compression rate is at least 100. We want it to be between 100 and 120 compressions per minute. We are at 30 to 2 for all patients with a single rescuer. If we have a child or an infant, we can drop to 15 compressions to 2 ventilations for 2 rescuer CPR. Okay, but nonetheless, the sooner we get one of those airways in place and we can do continuous compressions, the better off we're going to be. All right, so I think we've covered that stuff. Rapid defibrillation we talked about. Using the defibrillator is something that you've already talked about and done in class. Remember, all you have to do is turn it on, follow instructions. Pretty simple. There's an important point to be made, on this slide here. Rapid transport to the hospital may be the most time-efficient means of obtaining ALS. So ALS is not just simply paramedics on an ambulance. ALS is any advanced life support which is included with your ER help. So if we get ROSC, okay, and our protocols say that we're going to work the arrest where we find them, we're not going to move the patient until we get ROSC. If we don't revive the patient after 30 minutes, then there's a chance that we'll be calling them in the field. Now, from a BLS perspective, because you can't do rhythm interpretation and stuff like that, your protocol would most likely be different. In our system, we don't have any just plain old BLS rigs. Everything is ALS. So you'll have to look at your system-specific protocols depending on where you decide to go work. But generally speaking, if we can get the patient to the hospital, that is the better option for them. And think about this, if a person, if we have an adult that's 200 pounds that goes down in cardiac arrest, yeah, we're going to work them where we find them. Okay, it's going to be very difficult to move them, especially to do so without interrupting compressions for too long. However, if I've got a 6-month-old baby that's not breathing in front of me, I can easily do compressions and run out to the ambulance. And I'll tell you what, that's exactly how it's going to play out. If I can pick that baby up in my arms, I can be out to the ambulance in 10 seconds while doing compressions as I carry the child. That's how it's going to play out. And we're going to jump in the back of that ambulance, and we're going to do 100% of our interventions in the back of a moving ambulance as we move toward the hospital, because there's a good chance that the hospital is going to have resources available that we won't. The integrated post-cardiac arrest care, that is stuff that will, again, most likely be done at the hospital. They have different protocols, including things like hypothermia and different medications that they can do to try to improve the chances that the patient will remain neurologically intact after the arrest, okay, or after the recovery. Lots of different things. That's not something we're going to talk about, nor will you be tested on it. But just understand that we want to make sure that they're at a hospital that has the ability to provide that post-cardiac arrest care. Other things post-cardiac arrest is if we have time to do these things, right? If we get ROSC and we're transporting, doing things like an EKG, evaluating their vital signs, treating those things appropriately are all important. The hypothermia at the bottom there, again, you may have a protocol for that in your system, but more than likely you will not. There's a lot of concerns with the efficacy of post-cardiac arrest hypothermia, and more than likely they are not going to be prescribing that type of procedure for BLS providers. All right, EMT provides two links in the chain of survival, early CPR and early defibrillation. Those are the two most important things in the chain of survival, right? I spent a lot of time as an EMT, and I couldn't wait to become a paramedic because I felt as an EMT I was useless. I couldn't start IVs. I couldn't do all these fancy advanced interventions and procedures. So I really looked forward to going to paramedic. And as I got through paramedic and I started doing IVs and all these fancy things, I'm like, wow, this is cool. Now I can really help people. And then from there I went into education. And as an educator, I started looking at things, much more in depth, well beyond the surface there. And I began to realize that I was just as effective as an EMT as I am a paramedic. Because in the case of cardiac arrest, the most important thing you can do is good quality compressions and early defibrillation. And if you can make that happen, that's going to be the greatest chances at survival for our patients. It's not all the drugs that I pump into them. It's not all the other fancy procedures, the intraosseous needle or the IV access. It's just simply good quality compressions and early defibrillation. Okay. So from here, I think we're going to end up skipping through a lot of these other things because we're going to actually practice management of cardiac arrest in class. And we will discuss all the things that we should or should not do. AED use are things that we've already talked about. We know the difference between automatic and semi-automatic. Virtually all of the AEDs that you guys carry should be semi-automatic, requiring you to actually push the shock button in order for it to work. Monophasic AEDs are, I don't believe that they even exist anymore. Most of all of those should have been phased out by now. Everything remaining should be what's called biphasic. And essentially what a biphasic AED does is it sends a little mini shock one direction from one pad to another, and it measures the amount of resistance between the pads. It automatically calculates, and then it sends another shock back the opposite direction at the appropriate energy level to actually be effective. That whole process still happens in just a split second, though. All right, so I think we're good there. Let me skip through a couple more of these slides, and we'll pick up on some of the more important things in just a second. All right, so I skipped ahead a few slides, and we're going to transition here into post-resuscitation care. In the event that you are able to restore a pulse and the patient now is able to sustain it on their own, a few things we need to keep in mind. More than likely, because the amount of time that the patient was down or without oxygen, they won't be breathing on their own. So we will have to continue to breathe for them. Throughout both the arrest and post-arrest periods, it's really important that we don't hyperventilate our patients. By hyperventilating, what ends up happening is we bag off too much carbon dioxide. And all that additional carbon dioxide that gets bagged off takes them down, takes the CO2 levels too low. And the result of that is vasoconstriction. Particularly up in the brain. The blood vessels constrict down, it reduces blood flow to the brain, and it will further cause issues as far as perfusion of the brain itself. So hyperventilation is always going to be bad. And what that means is that even though our adrenaline is pumping because we're working this cardiac arrest patient, we still have to approach it from a calm manner. If I know that I should be delivering one ventilation every 6 seconds, then I should be counting 1 1,000, 2 1,000, 3 1,000, 4 1,000, all the way up to 6, right? And then I deliver that ventilation. And when you do it, that's really a long time between breaths. What typically ends up happening is you'll get a care provider that's providing ventilations, and they'll squeeze the bag, and then they'll go 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6 1,000 bag. And in doing that, because their adrenaline is causing them to count faster, they're hyperventilating. And then we have that lack of perfusion to the brain. So it's not just the person's job who is ventilating to watch this, but it's everybody's. And especially if you have a more seasoned provider with you that have worked a few cardiac arrests in their time, usually their stress levels are slightly lower, and they can look at things a little bit more objectively and say, hey, you're bagging too fast. I really need you to slow it down. The other thing that we have now is some monitors have the ability to monitor end tidal CO2. So we can put a little adapter on the BVM there that'll actually tell us with a numerical reading how much carbon dioxide is being expelled by the patient with each breath. And we want that to be between 35 and 45. Okay? As we get outside of that range, we have the potential for issues. So if I'm bagging my patient too quickly because I'm amped up with adrenaline, I'm bagging off too much carbon dioxide, and as a result, that end-tidal CO2 level will go down. So if I'm looking at a digital readout on my monitor and I've got EtCO2 reading of 28, that's too low. It's outside of my 35 to 45 range. So all I would do is I would slow down my ventilatory rate, allowing the patient to retain a little bit more carbon dioxide in between each breath. And as I slow down my bagging rate, eventually I should start to see that CO2 level increase. Okay, so just a few things to think about. We'll continuously reassess. It says, frequently every 5 minutes. You're going to assess this patient nonstop. You may do vital signs every 5 minutes, right? Try to monitor their new blood pressure and pulse rate, but generally speaking, you'll continuously reassess these patients. And then again, the hypothermia protocols will most likely be reserved for the hospital. If the patient drops down and has no pulse again, then we may need to go back to CPR. Okay, we'll talk more about what the AED can interpret and why it says pulse or shock or no shock advised, depending on the different circumstances. We also want to make sure that we're providing a sufficient amount of oxygen. We do not need the SpO2 level to go above 95% though. If we can get their SpO2 in the 94 to 95% range, that's perfectly acceptable. We don't need it to go above that. As a matter of fact, there are some potential risks if the oxygen level goes too high for these patients. So again, there's a good chance if we get a pulse back that they're going to go back into cardiac arrest. And if that's the case, we just go back and start over again. The difference is if we see, if we're checking a pulse and we realize, oh my goodness, they don't have a pulse again, we should immediately tell the AED to analyze the rhythm and go from there. Okay. Obviously, if the AED says shock advised, we're going to go ahead and deliver that shock. If it says no shock advised, if I can't feel a pulse, we're going to go to compressions then. Witnessed arrests are going to have the highest likelihoods of survival, just because if it's out of the hospital and no EMS providers are available, at least we got 911 called right away. And the other benefit is if the EMS providers are there and they witness the arrest, they can immediately defibrillate the patient. All right. A couple contraindications to AED use, things that we should be aware of. If the pads are too large, especially if we're using adult pads on a child for whatever reason, if we don't have the appropriate size pads, we can do what's called anterior posterior. So we'll put one pad over the center of the chest, one pad between the shoulder blades on the back, and then we can deliver the shock that way. If the patient is covered in water, we'll just quickly wipe the excess water away. It's okay if their skin is still damp or moist. As a matter of fact, a lot of patients, especially if they were having a cardiac event prior to going into cardiac arrest, they will be profusely sweating. And it will be enough to saturate the person's shirt. Not a big deal. We're going to cut the shirt open. We're going to quickly wipe away the excess sweat. We're going to stick those pads on, and off we go. Hypothermia, we also have to be careful. So with hypothermia, the heart, let's say that we have a conscious patient that we found out in the woods and they're severely hypothermic from being out overnight for a few days. What ends up happening then is their heart is at risk to go into a dysrhythmia. It's very irritable because of the hypothermia. So we have to be very careful with those patients not to jostle them around too much, not to obviously drop them or impact the chest that could throw that irritated heart into VFib or another rhythm. But in this case here, if they are hypothermic, let's say that we found a patient out on the sidewalk in cardiac arrest. We have to be careful defibrillating those patients because, again, the heart won't function well if it is cold. We need to do some good quality CPR. We need to begin to warm the patients up. Defibrillation will be more effective once the patient has been warmed. And your protocols will dictate exactly what to do or how to do it. If the patient's touching anything metallic, we should be very careful, obviously, right? Then the energy can be transmitted onto that metallic object and then to anybody else that could be touching it. But here's the thing. With the new modern technology, I believe not too far into the future, you're going to see a change in the procedures where you can actually continue to do compressions even while the shock is delivered. Okay, that's not the case yet, so don't do it. But you'll see that using pads instead of paddles now, and the biphasic instead of monophasic technologies. All these things are making it so there is much less risk to the rescuers and more effectiveness for the patient themselves. So I think we'll start to see some changes there. Obviously, if they're taking nitro patches, or if they have nitro patches or any other type of patch for that matter, where the pads are going to be, we need to remove those patches. The nitroglycerin patch, regardless of if it comes in contact with a pad, we need to remove it, because as we're doing CPR, what we're trying to do is get vasoconstriction. And if we have a nitroglycerin patch on there that's dilating, it's working against us. All right, so we'll again talk about all these different special considerations and processes in class itself and go from there. Mechanical CPR devices. A lot of places are starting to get different mechanical CPR devices, the most popular of which is called a Lucas device. And what that is that's actually, it's a device. You slide a board underneath the patient. You attach this device over their chest that attaches to the board, and then it's like a plunger. And that plunger goes down and does the CPR compressions for you. The benefit of the Lucas device or any other mechanical device is that you get a consistent depth, you get a consistent rate, and nobody is having to do compressions and get tired out. So there's a lot of benefit to these, but they're still pretty expensive, so not everybody has them. You'll also have to do manual compressions until something like this could get set up, okay? And then we also have to consider the potential for terminating resuscitation. So obviously reasons that we would stop CPR or resuscitative efforts would be if we restore a pulse, that's a positive outcome. The other option would be, though, if we are working on the arrest for a period of time and we have had no changes. And in those situations, you may be allowed to terminate the arrest on scene with the orders or permission of medical control. And your local protocols will dictate whether or not you can or cannot do that. I think those are the big things. A couple videos that you can watch through my Brady Lab if you'd like. Other than that, that concludes Chapter 18. And we look forward to talking some more about this in class. Enjoy the rest of your day.